So have you ever experienced that incredibly frustrating cycle of recurring pain? Maybe you finally cured this severe ache in your forearm, only for it to mysteriously pop right back up the very next time you swung a golf club. Or perhaps you shook off a sudden tension headache, but sure enough, the exact same pain crept back the following week. It feels like you're constantly treating the symptom, right? But you're entirely missing the root cause.
Well, let's dive into this. Welcome to This Explainer, where we're going to lay out a structured, step-by-step roadmap for tackling persistent muscle and nerve pain. We're going to look at the exact clinical stages of myofascial and radiating pain, and how treating them effectively isn't just about what you do, but crucially, when you do it.
Here's our roadmap for the explainer today. First, decoding myofascial pain. Then, we'll move through the acute stage, the subacute stage, and the settled stage. And finally, we'll wrap up with comprehensive team management, because matching the treatment complexity to the severity stage is the ultimate secret to breaking that cycle of pain.
Let's start with Part 1, Decoding Myofascial Pain. Before we can effectively treat this condition, we obviously have to understand what it actually is. A trigger point isn't just your standard sore muscle. It's a highly irritable spot located within a taut band of skeletal muscle. But here is the real kicker. It refers pain to entirely other areas. That means a single knot hidden away in one muscle can literally cause a disabling web of pain somewhere completely different in your body.
And this brilliantly illustrates the whole problem with treating complex composite myofascial pain. There's this fantastic analogy in the clinical literature. Imagine your house has been burglarized. You catch the burglar, but the theft just keeps happening. Why? Well, because there is another burglar in the house. When you have composite pain, you might successfully inactivate one trigger point, catching one burglar, so to speak, but the pain remains because other trigger points are still actively referring pain to that exact same spot.
Take a look at the X marks here on the jaw and neck. Those represent the primary trigger points, but notice those red dotted areas? The pain is actually being felt all the way across the face, the ear, and the temples. So a patient might come in complaining of severe facial pain, but the true source is actually a hidden trigger point down in the neck. If you don't treat that source, the symptom is just going to keep coming back.
Moving on to Part 2, the acute stage.
In the acute stage, everything about the clinical approach has to physically and methodically slow down. We're looking at a recent onset here, just in the past few weeks. It's usually one distinct episode of pain involving maybe just one or two muscles. Think of that sudden, severe, aching forearm pain you get right after an unaccustomed, repetitive activity, like, say, forcefully gripping a new tool or playing 18 holes of golf after a long winter off.
Now, because the injury is so fresh and the muscles are severely traumatized, the approach here is incredibly delicate. We aren't forcing a single thing. Actually, the clinical term they use is coaxing. First, we use palliation to protect the muscle. Then practitioners often use a vapocoolant spray applied to the skin while just gently stretching the muscle. Gravity is basically doing most of the work. You stop the absolute second there's a significant increase in pain. We are coaxing that muscle out of its shortened state, never ever forcing it.
If we look at acute forearm and elbow pain specifically, perhaps involving entrapment of the median nerve, the protocol strictly reflects this protective goal. The arm is actively immobilized using a splint at 90 degrees of flexion, which helps reduce compression. We bring in physical agents like ice and electric stimulation. Movement, that is restricted exclusively to pain-free nerve mobility. Early on, the absolute goal is simply protection and pain-free rest. All right, Part 3, the subacute stage.
As the patient actually begins to heal, they transition from the acute stage right into the subacute stage. We move away from delicate coaxing and get into calculated action. In this moderate stage, it takes much stronger palpatory provocation to reproduce the pain. The strict immobilization and icing of the acute phase get replaced by soft tissue mobilization. We're actively working the fascial tissues now to address that nerve entrapment.
So the actionable goals for this moderate stage shift heavily toward restoring function. First up, we must inactivate those primary trigger points. Then, we use soft tissue mobilization to free up those restrictive tissues. Finally, the focus becomes gradually restoring normal strength and increasing the extensibility of the extremity, but crucially, all without overloading those still vulnerable muscles.
Next up, Part 4, the settled stage.
But what happens when this pain condition has been hanging around for months or, even years? When a condition becomes chronic or settled, the rules change entirely. The symptoms might be mild day to day,
maybe only flaring up after really extensive repetitive activities, but the underlying dysfunction is deep. Managing chronic pain, especially with multiple regions of persistent pain and widespread trigger points, requires a highly complex strategy. We're talking about treatments that can sometimes span up to a full year.
Notice the radical shift in modalities as a condition settles into a chronic state. For physical agents, we go from acute ice all the way to settled moist heat and continuous ultrasound. In therapy, we shift from pure immobilization to progressive strengthening and even plyometrics. And for direct interventions, simple surface cooling gives way to invasive procedures, things like trigger point injections with local anesthetics or dry needling to directly mechanically disrupt those really stubborn trigger points.
But hey, clinical interventions aren't enough on their own. In the settled stage, behavioral modification is absolutely key to avoiding recurrence. Here are some highly actionable takeaways from the research for your own self-care. For jaw and neck pain, eat a soft diet, avoid stimulants like caffeine, and consciously try to keep your teeth apart. For all myofascial pain, correct that forward head posture, radically modify the daily repetitive activities that overload your muscles, and commit to regular, daily self-stretching.
And finally, Part 5, Comprehensive Team Management.
Because, ultimately, complex myofascial pain just cannot be cured in a vacuum by a single practitioner. If a patient has severe jaw and neck pain, the effort is split evenly. The dentist or medical doctor establishes the diagnosis, provides splints, and performs those trigger point injections. The physical therapist works on restoring normal muscle length, posture, and joint function. And crucially, a health psychologist holds equal weight in this entire process. Why? Because psychological stress causes reflex muscle tension, which directly perpetuates the pain cycle.
And that brings us to the core thesis of this entire explainer. If there's one single takeaway you walk away with today, let it be this. The key to success lies in matching the management complexity with the patient's condition complexity. If you try to apply a simple, acute treatment to a complex chronic condition, it is going to fail.
That is exactly why the initial evaluation process is so utterly vital. It isn't just about finding the pain. It's about identifying the trigger points, mapping out the referred pain areas, and uncovering the contributing factors. Are there macro traumas from some old injury? Are there parafunctional habits, like aggressively clenching your teeth at night? Identifying and changing these perpetuating habits is what actually closes the loop on treatment and finally prevents the pain from coming back.
So as we wrap up this roadmap to managing myofascial pain, I want to leave you with a somewhat provocative question to think about. Even if your pain is completely gone right now, what latent trigger points are still hiding in your daily posture, just waiting for the exact right moment to flare up again? Thank you so much for joining me on this explainer, and remember, lasting relief is all about structure, timing, and uncovering what's really going on beneath the surface.